Hello, my name is Jolie Puckett, RN, BSN, and DNP student of Jacksonville State University. This is my project X-Treme Makeover for the NU 713 class of the Organizational and Systems Leadership for the Advanced Practice Nurse, Spring 2022. This is the table of contents for my project. These are the learning outcomes for my project. Miscommunication in the workplace. Reflecting on my previous work environment, one event of miscommunication comes to mind ahead of the others. It was summer 2020, and the COVID-19 pandemic was at an all-time high. I was an intensive care unit nurse and had been for 3 years. I had our first COVID-19 positive patient on March 3rd, 2020. Along with a great group of people, I went on to open our COVID-19 ICU unit. I was the charge nurse for around half of the time. I helped open and run the COVID-19 step-down med-surg unit and created many policies for my organization. For background, emotions were running high from everyone in the hospital and community. I had admitted a patient who was positive for COVID-19. This patient was the husband of a nurse employed at my organization. Our COVID-19 positive patients were not allowed visitors at this time. The nurse had used her employee badge to get into the emergency care center. She was upset and verbally took it out on the staff. She was escorted out of the hospital. Our director of nursing told her to stay home. She did not need to come back to work at this time. She was also presumed COVID-19 positive as well. For this project, we will call my patient Mr. Smith. Mr. Smith was with me in the ICU for quite a few days and was progressively getting worse as the weekend went on. Mr. Smith had muscular dystrophy and prepared for his death for many years in advance. He was wheelchair-bound but able to do most things on his own. He had completed a Georgia Advanced Directive over 15 years ago. Even though Mr. Smith was progressively getting worse, he kept his code status as a DNR/DNI, which meant do not resuscitate or do not intubate. This meant that we would not revive him or place him on a ventilator. On Sunday, he was getting dialysis when his heart rate dropped to 40. He was already on a 100% non-rebreather mask at 15 liters. He was tachypnic at 38 breaths per minute. He refused to wear the continuous positive airway pressure system. He was adamant that his wife be by his side. He was exhausted. He was crying and gasping for air while I was on the phone with his wife, who was crying and begging me to be with him. He was nearing the end of his COVID-19 journey, and I knew she had been told to stay home. I called my chief nursing officer, who was the one who banned the wife from the hospital. After extensive discussion, she agreed to let Mrs. Smith come see her husband. I called the wife, and she was already downstairs, begging to come up to see his room. She had slept in her car all night, awaiting the call that he didn't make it through the night. They embraced each other, and he finally let me place the CPAP on him. He was on the maximum settings. The images of this man's struggle are burned into my memory forever. My director texted me later that morning saying that the director of nursing had called him, explaining the situation and the need for the wife to be at bedside. I explained why I called the DO in, because of the ban that she had placed on the wife, and he seemed fine with everything. I tell you this backstory because this was a heart-wrenching situation. I did everything to keep this man alive and let his wife be with him in what appeared to be his last moments on earth. My clinical judgment was that I needed the wife to be at the hospital. The rest of the day was touch and go. He made it through the night. The next morning at 7:30, my manager and director came up to the COVID unit. We were going to have a staff meeting that morning. I went up to talk to them about the situation, and my manager started yelling at me. I was in such shock. As I watched anger pour out of them, I felt so small. They were both so upset with me. My manager stated that she didn't appreciate not knowing what was going on in her unit. I did not even have time to explain myself and explain that the patient was going to die alone. To me, his wife was the only thing that could have saved him. I tried to speak out, but was shot down. Tears streamed down my face, and I stood with my mouth wide open, surrounded by about 10 of my colleagues while being degraded. I was also the charge nurse that day, and it added to the pain. I stood there during the staff meeting with crocodile tears flowing out of my eyes. I had never gotten in trouble at work. I had never had a write-up or even a verbal warning of any kind. My manager had called me her Christmas present to the ICU because she was glad to have me working for her. At the end of the staff meeting, I put on my personal protective equipment, including a full face mask, and went and cried for 30 minutes in my unconscious patient's room. I contemplated a lot during this time, and I wanted to leave the organization that I had worked for 6 years. I had never felt so humiliated in my life. I was borderline speechless for the remainder of the day. My director failed to communicate to my manager that I had spoken with him and my DON. That same afternoon, my director walked down to the unit and asked me to open the modular 20-bed COVID unit. He wanted me to open and run the unit 4 days a week. In his words, it was, since I have been doing such a great job here, and that he really appreciates everything I do for this organization, and my hard work doesn't go unnoticed. Note that this was the same day that I had just got humiliated in front of all of my coworkers. I never got an apology from either of them. I lost every bit of respect I had for my manager and director that day. Mr. Smith fought a hard battle. He was able to go home after some time in the hospital. He was home with his wife for 29 days before he passed away from COVID-19 complications in the comfort of his home and in his wife's arms. And this is a picture of me during those times. How did the miscommunication occur? I assumed I should call the person who prohibited Mrs. Smith from coming to the hospital to get this special permission. We were on borrowed time and I needed to talk to the person who could permit his wife to come ASAP. My manager would have called the DON anyway, and it was 7:15 on a Sunday morning. I thought I was doing the right thing by calling the DON directly. My director failed to tell my manager that I had talked to him yesterday about the incident. My manager found out about the wife being in the room on Monday morning when she walked up to the unit, and then proceeded to yell at me. She was caught off guard. I failed to let my manager know at the time of the incident because I spent most of my day trying to keep Mr. Smith alive. What were the variables influencing the situation? At the beginning of the pandemic, much was unknown. We were all overworked. I was working 72 hours a week as a charge nurse of a unit where the patient outcomes were not good. Emotions were high, and my management and I were both fearful and stressed. The patient was on the brink of death. He was a DNR DNI, and I could not resuscitate him if something did go wrong. We were pressed for time. We all thought Mr. Smith was going to die, including Mr. Smith and his wife. The statistics were if you had COVID-19 and were placed on a ventilator, your probability of living was 1 out of 10. This meant that you had a 9 out of 10 chance of dying. He needed to be intubated, but we respected his code status. We wanted them to be able to be together. They were very codependent on each other. They had prepared for his death for years in advance due to his terminal condition. However, they were not ready yet. This was a sudden change. I also was a charge nurse. We were intubating patients that day. We had a couple of patients pass away. We were running the rapid responses for the medical COVID-19 unit. Calling my manager was not at the top of my priority list at the time. I recently went into management about 6 months ago. I can speak on the conversations with my fellow ICU nurses, medical surgical nurses, and management colleagues. Some of the conversations that we have had is that ICU travel nurses are coming in and being paid 4 times what we were making. It was $27 an hour at the time, and the nurses coming in were making $110 an hour. Many nurses wanted to go travel for more money. Many nurses also did not want to leave the organization due to how great of an environment it is compared to the other local hospital. We have great nurse-patient ratios in the ICU being 2 to 1. The other local hospital was 4 to 1. As COVID-19 cases increased, the staffing became worse. We had to open more beds to hold more patients. Staffing is pulled to the bare minimum, and my fellow med-surg nurses debated leaving. We talked about how COVID-19 has changed nursing and healthcare, how patients are coming in sicker than they were 5 years ago. My management team talked about how new nurses were being thrown in when nursing is not the best. They're experiencing nurse burnout at an astronomical pace. We've had new nurses leave nursing altogether within the past year. Another thing that we talked about is how thankful we were that our organization supplied P100 full face masks and proper PPE. We watched New York nurses wear trash bags and reuse regular masks. What these conversations tell about the culture of my organization. Staffing is excellent when COVID-19 numbers are not high. Our organization supports us by providing us with the best equipment and PPE. My organization cares more about paying travel nurses with big money than nurses who have stayed loyal to the organization. Although this is not true, many teammates have expressed this. We do not have enough beds to support the community with COVID-19 numbers increasing. My colleagues genuinely do not want to leave the organization, but they may do so if the right opportunity presents itself. People really do love to work in my organization. We have all the resources we could possibly need, and the hospital fosters an environment where people do not want to leave. Patterns of relating, or how people interact with each other, form an organization's culture. There may be habits of relating, such as a preference or an email communication, that results in specific patterns of relating that are different from that of an organization with a preference or face-to-face conversations. My organization uses email and Microsoft Teams as the primary form of communication. We are a large organization, and this type of meeting allows people to attend multiple sessions a day. We went to the Microsoft Teams approach when the COVID-19 pandemic began, and this allowed social distancing while utilizing the video features that remain face-to-face. We do have rituals within the organization. We have a daily safety huddle that includes everyone in management. There are about 100 people at this 8 a.m. meeting every day. An executive team member leads it. Managers are asked to speak on safety issues on their units. This is all led by an executive and is highly formal. This is not a meeting for gossip or otherwise. The whole meeting takes about 15 minutes at the beginning of the day. Patterns of meaning are specific themes that exist in an organization. Atrium Health Floyd, my organization's mission statement: to improve health, elevate hope, and advance healing for all. The vision statement is to be the natural leader for health, learning, and community. We also have a value statement that is our 5 culture commitments. They are posted around the entire hospital. We focus on one of these culture commitments per month, and the focus one is the background of each computer. How do we talk within the organization? Our ways of speaking in organizations are patterns that can reinforce and stabilize culture. Leadership in my organization is supposed to present a positive attitude even when the times are hard. My employees often speak on how I have remained positive over these past couple of years. I do this purposefully. I know that being around negative people will impact those around you. My management colleagues and I actively listen to our employees. We have face-to-face, one-on-one meetings with employees daily. We want to know what is going on and how we can help them reach their goals or even better their day. I focus when the employees talk to me, and I try to be present in the moment. I try not to stay in my office too long. I'm over 54 beds and 3 surgical units. It can be quite busy. Mindfulness is described as the energy of being aware and awake in the present moment. To be mindful is to be present and at one with those around you and what they are doing. I have previously been in situations where I felt the person did not care about what I was doing or what I had to say. The person was not fully present when I was talking. During the hustle and bustle of the workday, many people forget how to be mindful of one another. I see this as nursing students who want to learn, but some nurses push them away. Those nurses need to be aware of the students and remember that they were once in that position. There is a need and value of holding multiple perspectives as useful and viable. Innovation represents the yet-to-be-formed idea, process, or product that may emerge from ongoing conversations and the introduction of sufficient novelty. My organization promotes innovation. When I was working in ICU, we had to be highly creative and innovative during the COVID-19 pandemic. We introduced many ideas and pushed them up to leadership. The leadership team quickly voted, and we were able to implement many of these processes. We work with fellow nurses and physicians who constantly strive to do what is best for the patients. We utilize shared governance, and this process allows frontline staff to get together and develop what needs to change within the organization. We also use preventable harm. These are meetings conducted after errors have occurred within the workplace. A group of about 10 people get together at a round table to discuss what mistakes were made and how we can fix it so that it prevents patient harm in the future. These are often medication errors. This promotes interdisciplinary teamwork and talks within the workplace. The nurse is not in trouble for having a medication error. We know it was an accident. This is just a meeting to prevent future harm. Reflecting on my story, I would have done things differently. I do not want what happened to me to happen to anyone else. I would follow the chain of command, calling my manager first, then my director, then my DOM. We implemented critical COVID-19 patients to have a designated visitor. In management, I want to praise in public and reprimand in private. If there is an issue, I would not want to feel attacked by the people who are above me. I would not want to wait till the last minute, and I would want to plan in advance. My DON had chosen me to run the COVID-19 modular unit 2 months before opening it. My director waited until 4 days before we opened to tell me. I was even promoted with a monetary increase the same day that my character was torn apart in front of everyone else. We would attend crucial conversations. This is a leadership training on how to talk to people. I plan on taking this class in the next month. If I am having a bad day, my staff may be impacted, and I need to put on a public face and not take my anger out on them. Management and frontline staff should be cohesively working together to promote positive changes in the workplace. I want to promote a positive, healthy, and thriving work. I can relate to my staff because I have been in their shoes for the past 7 years. And my employees will never feel how I felt that day due to me. I will not call them out in front of everyone, and we will have private counseling sessions. I would think before acting and treat them how I want to be treated, even if they are in the wrong. We have also started paying incentives to stay instead of travel. Incentives are almost equal to working as a travel nurse, making over $90 an hour on an extra day. We are in talks every week on how we can promote strategies to retain our staff. For the patterns of meaning, I brought up the culture commitments. Ways of being present when they come to me with an issue or happy updates about their life, feedback from the executive team. I'm updating my employees daily on information that has been given to me. I'm talking to them openly about things that have happened to me as a nurse, speaking with employees often about their performance and ways to improve. I want my team to feel empowered, educated, and supported. In conclusion, I had a bad experience with miscommunication. As a manager, I know that I will do better. My organization promotes a positive, healthy, and innovative work environment. Communication is key to performing effective patient care and functioning well as an organization. These are my references. Thank you for listening in.